Okay, so we have acquired dysgraphia, and our treatment is anagram and copy treatment, or ACT, and recall and copy treatment, or CART. So ACT and CART can be once or twice a week, usually only lasting about a month, while also incorporating at-home practice. And first, you must establish a baseline, and this can be done by gathering a list of functionally useful words in conjunction with the participant and their family. The participants assessed on the word list by being asked to spell the word to dictation on 3 occasions, responding within 20 seconds. Treatment can then either be unimodal or multimodal, which we go into in more detail about in the paper. But on a study in 2016 by Teal et al., the treatment is basically implementing a cueing hierarchy as said before, and first the participants asked to copy the written word from a card. Feedback is given from the therapist. If the word was incorrectly copied or no response was given, the therapist is asked the participant to copy the word from the card 2 more times. Feedback is given again. If the word was copied correctly the first time, the target word and the participant's correct response are covered, and the participant's asked to write the target word from memory. Feedback is again given. If the second response was incorrect or no response was given again, the card was shown again and the participant was instructed to copy from it. If correct, all the correct versions of the word were covered and the participants instructed to again write from memory. More feedback is given from the therapist. After each attempt, the therapist verbally produces the target word, but the participants instructed never to say the target word out loud at any time. After these 3 attempts at writing the word, the therapist proceeds to the next target item. Spoken repetition and written practice can be incorporated, and those are expanded on in the paper. There's a specific cueing hierarchy mentioned by an article from 1999 by Beeson, and it basically has a picture of a target word. The therapist elicits a response from the participant. If they correctly name the target word, then they move on to the next stimulus item. But if they cannot identify it just from the picture, they are given letters that make the target word, and they are said, for example, make the word dog from these letters. If they can do it, then they copy it 3 times, move on. But if they cannot, then the clinician puts them together correctly. If they are successful in arranging the words correctly, then 2 foils are added and it's expanded upon in that way. And more detail is given on that, but that is an example of a cueing hierarchy specifically used in ACT and CART treatment.
Based off of separate research conducted by Balasubramanian and Rapp, the primary target areas for dysgraphia treatment are memory and motor behaviors. The lexical long-term memory route activates the phonological representation of the word, which then allows access to the orthographic output lexicon, or the OOL. This is the long-term memory repository of the spelling of familiar words. The second route, or sublexical route, yields phonologically plausible spellings. Then, both routes generate spellings via the graphemic buffer, or the short-term working memory. These spellings are then produced in writing by engaging the appropriate motor systems. Thus, many treatments for dysgraphia target long-term memory, short-term working memory, and motor behaviors that are involved in written communication. When looking at recommendations for these techniques, it's important to always consider your individual client's needs and how they will benefit from these techniques. We recommend considering errorless training, choosing the correct route to target, and making any modifications your client may need. For example, in 2013, Beeson and colleagues conducted a study in which the client was using CART as well as a modified version of CART called T-CART. This involved using text messaging to assist in improving the patient's written communication.
So some appropriate patient populations to use with dysgraphia treatment include patients with aphasia, both fluent and non-fluent, people with Alzheimer's disease, apraxia of speech, people who have suffered from traumatic brain injuries or stroke damage, specifically with damage to the left hemisphere of the brain, and those who have experienced cerebrovascular accidents. So as far as what we found in our research regarding the efficacy of dysphagia treatments, there was a study completed by Thiel which compared a group using the unimodal approach to a group using a multimodal approach. They found that both produced improvements, but there was no significant difference between the different models. In the Ball study, they were testing ACT and CART on patients with severe aphasia. They did find that they made improvements, and they suggested further research to determine if the same would be found with patients with moderate aphasia. In the Beeson study, which also focused on ACT and CART efficacy, they found that the client made significant improvements even after the clinician therapy, and so they stated that CART was effective enough that it could take the place of clinician-directed treatment, and they indicated that further research could be done to determine if ACT is actually a necessary component or if CART could just stand alone.